Hopefully my talk will appear on the screen soon. This session today is devoted to oocyte quality, and I've been asked to talk specifically on stimulation and oocyte quality in patients with polycystic ovaries. This is something that probably everybody in the room will have considerable experience on. Polycystic patients are very commonly seen in the clinic, and they present us with a therapeutic challenge, both in terms of maximizing their pregnancy rate, but also specifically in these patients in doing so in a safe manner. Probably the worst thing that we see in our units is the epidemic of multiple pregnancy and also ovarian hyperstimulation syndrome. And this is a double challenge that we face in the management of these patients. So over the next 20 minutes or so, I'm going to talk a little bit about oocyte quality in these patients, a little bit about what the evidence is to show that there is problems or compromise in the oocyte quality, spend a little bit of time talking about the mechanisms underlying those abnormalities, and then talk about how that then impacts on our management with these patients and the different stimulation regimes that we can actually encounter. I'll touch briefly on pre-stimulation treatment, a little bit about recombinant or urinaries. We've already heard the talk this morning on the addition of myo-inositol, and then cover some alternative approaches, and finally finish off by looking at some IVM. So we'll try and condense that, and I'll try and give you just the main points. So we all know that polycystic ovaries, as I said, is very common. It's not a very well understood condition, despite its preponderance, and despite the fact that it's been around for a long time. This painting is 300 years old, showing a patient with rather severe polycystic ovaries breastfeeding a baby. We know it's associated with menstrual dysfunction, irregular periods, irregular ovulation, as well as subfertility and hirsutism.